Mr. Chairman, thank you very much, and let me thank you and your staff for the continual effort for us to work together to find a path forward on a Labor H bill. I very much appreciate the attitude and approach that our staffs and you and I are taking. And I appreciate Dr. Collins and his other center directors being here today. This is a highlight, I think, for our subcommittee as we hear for some of the most recent and exciting developments as we face the challenges that disease provides. Science and research are the foundation of innovation, growth in our economy, and the solution to a myriad of issues that confront the health and well-being of our nation. NIH funding biomedical research is the catalyst behind many of the advances that are now helping Americans live longer and healthier lives. Because of the federal investment in biomedical research, U.S. cancer rates are now falling 1% each year, with each 1% decline saving our nation about $500 billion. The U.S. death rate from heart disease and stroke have declined more than 60% in the last half century. And between 1997 and 2006, the death rate among adults with diabetes declined 23%. However, health advances aside, and they are paramount, the reduction of healthcare costs in the future may be one of the most significant contributions to society that medical research provides. As baby boomers age, the cost of healthcare will continue to increase. For example, a study led by the economists at the RAND Corporation stated that the cost of dementia care is projected to double over the next 30 years, surpassing healthcare expenses for both heart disease and cancer. Without a way to prevent, cure or effectively treat dementia, it will be difficult, if not impossible, to rein in costs. But science has confronted similar health challenges in the past and has prevailed. In the mid-20th century, economists predicted polio would cost taxpayers $100 billion a year to treat patients in iron lung hotels. In the face of this challenge, medical research produced a solution to this devastating disease, and polio is now on the verge of being eradicated worldwide. In the next few years, we confront difficult spending choices. I believe we must prioritize our federal commitment to NIH. It is crucial that our next generation of biomedical researchers, the ones who will develop better and more cost-effective health care, remain in the scientific research field. Without adequate and sustained federal support for medical research, trainees will be driven from medical fields or into the arms of our global competitors. Last year, China's government pledged to increase basic research investment by 26%, and will contribute more than $300 billion to biotechnology over the next 5 years. In the last 5 years, China's percentage of science and engineering degrees earned by university students was more than double those earned here in the United States. Without continued investment in NIH, we jeopardize our current scientific progress, risk losing a generation of scientists, and stunt our nation's global competitiveness. This is not a time to waver on America's commitment to NIH and to the health of all Americans. Mr. Chairman, thank you, and I look forward to working with you on these priorities. Dr. Collins, thank you very much for your compelling testimony. Dr. Varmus, thank you very much for coming to Kansas City. Thank you for visiting a couple of a research facility and a hospital. But thank you especially for riding your bike in support of raising money for cancer.
Along with barbecue.
Along with the barbecue, that's right. That was the real inducement. Thank you very much for highlighting Kansas City barbecue. Dr. Collins, and this may be for Dr. Landis because it's a follow-up to what the chairman was asking about. On this BRAIN initiative, the budget documents are not very specific in regard to what we should expect as far as budget requests, money to be spent over a time frame, the next 10 years. I was interested in kind of what are the goals in the short term of this project, and you outlined what, at least in the first 5 years, I guess is the significant goal. But what would we as a committee, what would we as members of the Senate expect the request to be in regard to the budget into the future?
So, very appropriate question. This is sort of like the Genome Project in 1988, where it was clear there was an opportunity and it wouldn't happen without a coordinated effort, particularly the focus on technology. But nobody was quite sure at that point what the trajectory could look like as far as accomplishing that goal. We're in the process right now of trying to define that, Senator, in the long term, over the next 10 or 15 years. What could be accomplished What would the steps be? What kind of technologies do we need? And what would the cost be? And so we brought together a really remarkable group of visionary neuroscientists in a group co-chaired by Corey Bargman from Rockefeller and Bill Newsom from Stanford, along with 13 other remarkable folks. And we've asked them, in the course of the next few months, and they're hard at work at this, to lay out some initial milestones of what this project needs to accomplish. And by the summer of 2014, to have a much more detailed roadmap of where the BRAIN initiative needs to go and how quickly it can get there. So frankly, I don't have a clear answer to your question at the moment in terms of what the budget trajectory of this might be over the next 10 or 15 years. We have to be sure we have the science plan laid out.
And there's no justifiable reason that we should expect that plan at this point. I mean, that's just not accomplishable at this point. Before we start down this path, we're not going to know what to expect.
I think at this point, it would be premature to try to attach budget numbers to a scientific plan that hasn't quite formed in a coalesced way and been embraced and endorsed by all of the scientific experts that we want to participate and to take part in this. So it is always been our view that if you're going to try to start something really bold, the first step is to map out the science, and then you figure out, okay, what does that mean in terms of the timetables and the costs? And of course, you have to set priorities within the realistic envelope of what costs might be available to you. And we recognize this may be a tough time to be starting a very ambitious project, but we just don't think it would be right to wait, given the opportunity.
Dr. Collins, this may be for you, as I don't think the NCAT director is here.
He is not.
Let me ask about the status of NCATS. I was supportive of its establishment, and I think that's now about 1.5 years ago. And I'd be interested in having you bring me up to date on its developments. I think one of the environments in which NCAT now works is that with the economic condition, the fiscal condition that we face, private drug companies there's this gap, what's been described as a valley of death between scientific discovery on the one side and patient benefit and commercial success on the other. The goal of NCATS has been to fill that valley, and what kind of success are we having in doing that?
Well, thank you for the question, and let me say right up front how wonderful it's been for Chris Austin, the director of NCATS, to work with folks in Kansas at the university and with the Leukemia and Lymphoma Society on a few groundbreaking projects, particularly one on chronic lymphocytic leukemia, which is actually a good example of one of the things I want to mention that NCATS has catalyzed. And that is this whole idea of repurposing drugs that were developed for something but turn out to have a use for something else. The project working on with Kansas is a drug developed for rheumatoid arthritis, Oranafin, which turns out to have activity against leukemia, and more recently, to the delight of all of us, also against a very resistant kind of cancer called mantle cell lymphoma. The CLL protocol is already well along in a clinical trial, and this is an amazing quick turnaround, because if you had to start from scratch, it would take years and tens of millions of dollars to get to a clinical trial. But if you can identify a compound and try it for a new purpose, you already have all that background data, and you shave off years and many tens of millions of dollars in cost. So NCATS is, in fact, catalyzing that kind of repurposing, both for drugs that have already been approved, but also in working with companies, 8 of them, they have agreed to make 58 compounds available for new uses that actually turned out not to be effective for the original use, but the drugs are known to be safe. This is crowdsourcing, if you will, the opportunity to find a new use for a really heavily invested compound that may turn out to have failed for disease A, but might be just the thing for disease B. NCATS is also working with the FDA and with DARPA on developing a new and very high-tech way of identifying whether or not a drug is going to be safe before you ever give it to that first human patient, using a biochip depending upon the stem cell, iPS cell technology. And NCATS also serves now as the home for the largest investment in clinical and translational science, namely our CTSAs, of which there are 60 across the country in many of your states, and basically then bringing that network together in a way that makes the whole really much greater than the sum of the parts, sort of CTSA 2.0, as we are starting to call it. So I think even though NCATS has only been around for, a year and maybe 5 months, The evidence is very clear that this is an opportunity that we have grabbed onto. The private sector is enthusiastic about the way in which this serves as a complementary set of contributions to what they're doing. Academics are fired up about it. I think this has turned out to be a really good thing for NIH to do.
Very good. I assume you're the one who coined the phrase Valley of Death and now crowdsourcing. I will use it in my comments next.
I don't think I can take credit, but you're welcome to use the terms.
Dr. Gibbons, cardiovascular disease is the leading cause of death in the United States. It's certainly a driver of healthcare expenditures. I'm told it costs the U.S. Consumer, the patient, $312.6 billion a year. Sunday's New York Times had an article on NIH study that is using genetic sequencing to find factors that increase the risk of heart disease beyond the usual suspects of high cholesterol, high blood pressure, smoking, and diabetes. Would you tell us more about that study?
Well, thank you for that question. This is one of the great success stories, I think, in biomedical research, where discovery science related to the pathways that determine LDL cholesterol, the bad cholesterol metabolism, led to Nobel Prizes for Brown and Goldstein. There was a great public-private partnership that led to the identification of a target that would lower LDL cholesterol, that led to a drug, statins. And I suspect for those of us over 50, a lot of us in this room may even be on one, that was a breakthrough drug that's transformed medicine. And indeed, that public-private partnership is one that is critical to advancing medicine. The question now is that although we have studies that show the remarkable improvements of having patients on statins, unfortunately, there are still patients on statins who have a heart attack every few moments in this country. So that tells us there's still unfinished business. There's still some unsolved mysteries. That article related to us continuing to try to figure out those patients where we don't really understand all the risk factors, all the predictors of who's going to have a heart attack. And as you saw in that article, a devastating impact on a whole family that we really couldn't explain. But that's where we had these unprecedented opportunities. With new technologies, we're able to sequence parts of the genome and probe into why is this family so different and distinctive in a way that's really devastating to it. We're hopeful that that will identify new pathways that'll tell us more about the risks of heart attacks. That may recapitulate that story we just had with LDL cholesterol. That's the promise of the future. Those are the investments we need to make now for those breakthroughs tomorrow.
Is there enough research to give us a clue as to what those other factors may be?
Well, there's a lot of promise. Perhaps one example of sort of a harbinger of that relates to a molecule called PCSK9, in which a similar sort of strategy delved into the molecular determinants of, again, a group of families, a group of patients that had an abnormal level of LDL cholesterol. And the probing using modern genomic technologies unveiled this new gene and this other pathway that told us another potential target. And indeed, as part of the recapitulation of that public-private partnership, in which discovery science translated into drug development, indeed, a new drug has been developed that targets that same sort of pathway. And that's now in the midst of clinical trials to see if on top of statins or in a complementary way, going after this new target can actually give us more bang for the buck. Similarly, one of the things that we're learning is that although you have that bad cholesterol, what we're also appreciating is not just that clogging of the arteries, but it's also the activation of the body's immune system that sort of turns against the blood vessel and inflames it, just like your allergies flare up your sinuses. In that sense, the blood vessels are inflamed. And so what we're now looking at is new targets that may not only target the cholesterol level, but that inflammatory response that also promotes heart attacks. And that's where some of the great breakthroughs, I believe, are coming. And indeed, we're funding a study that's looking at tackling that inflammation part of the story to see if we can indeed make the next breakthrough.
I wish you great success.
Thank you.
Dr. Collins, I have very little time left, but as As people know, Kansas is a very rural state. I have concerns about clinical trials, and in order, I assume, for a clinical trial to have validity, it takes a wide range of demographics and characteristics. And it seems to me there are barriers toward some people based upon geography, age, other demographic and personal characteristics, perhaps fear of government research, lack of awareness of clinical trial availability. What can I do, and what is NIH doing, but what can I do as a senator in caring for Kansans to make certain they are aware of the opportunity to participate in clinical trials and potentially improve their health and save their lives?
It's a great question. NIH is by law in our clinical trials required to be sure we are reaching out to a diverse population. And we track that carefully, and all the individuals who review clinical trial grant proposals and the program staff who follow those make sure that we have a diversity of population involvement in the studies, whether it's heart disease, diabetes, cancer, or whatever. But of course, we are dependent upon public knowledge about the ability to be part of such trials, and I appreciate your question very much in that regard. There is a website called clinicaltrials.gov, which is heavily utilized, and every clinical trial that we support, and most of the ones supported by industry, are also listed on that site, and you can search it very readily to see for a particular condition and some particular part of the country where is a trial currently enrolling patients and what's the nature of that trial, and people can decide if they want to take part. Getting the word out about that would be a wonderful thing to do, and I appreciate very much your suggestion of helping with that. We would welcome that.
So if I could just add something, the NINDS recently set up a phase 2 clinical trials network called NeuroNext, 25 sites across the country, and one of them is at Kansas State University. And we are hoping to incorporate into the clinical trials undertaken by that network telemedicine, which would enable, for example, for stroke, for patients at a distance to be seen by and treatment recommended or randomization recommended through the main NeuroNext site. So we're very interested in engaging in this with you.
I like that answer. Thank you very much.